Okay, guys, welcome back. We're going to get into endocrine and hematologic emergencies, really covering diabetes and some of the, I guess, common and kind of uncommon hematologic emergencies, which just kind of like blood disorders that you guys may encounter as EMT basics. So, the actual endocrine system is basically one big giant communication center that controls many functions inside our body. And it secretes hormones for us. The actual glands of the endocrine system will secrete the hormones. Those hormones are basically chemical messengers, right? That produce some kind of response in our body. And the endocrine disorders that we're going to talk about usually cause some kind of internal communication process where our organs are not talking to each other, our organs are not talking to ourselves, the hormones are ineffective, and nothing's really talking to the brain at that point. So, the brain is the only organ in our body that does not need insulin to absorb glucose. Okay, it just takes as much sugar as it needs in order to process the other functions throughout the body. All the other organs and all the other cells in our bodies need insulin in order to get the glucose inside our cells, in order to help with the process of producing energy or producing ATP, which is that adenosine triphosphate. Without any insulin, okay, if we don't have, think of insulin as the keymaster or the gatekeeper, if you will, for the actual sugar in order for that sugar to get to the cells. Okay, so our pancreas is actually what is responsible for producing the insulin. And again, so remember that insulin is that actual gatekeeper that lets the glucose go into the cell. And it also holds storages of what's called glucagon. And glucagon is basically like anywhere between a 3 and 5 day storage of actually glucose itself. Just in case our body experiences some kind of trauma, some kind of infection, or we just don't eat, the body can actually survive on about 3 or 5 days from actually spilling the pancreas will actually start leaking that glucagon in order for our body to have that storage of sugar. In the pancreas itself, what's called the islets of Langerhans, they have two different types of cells. They have alpha and beta cells. The alpha cells themselves is actually what produces the glucagon, and then the beta cells is what actually helps us produce the insulin for our body. So the disease process that we're really going to focus on in this lecture, specifically for the basic level, is going to be diabetes. Okay, and diabetes affects the actual body's ability to use the actual glucose or sugar for fuel. It occurs in right just under 10% of the actual world population, and it feels like the majority of those people live right here in our area. We have a very big diabetic community in our area here, and we'll talk a little bit more about that as the lecture goes on. But it's really just a nasty disease process, and it can lead to all kinds of different complications. Specifically, if you're a diabetic with other complications like heart problems or respiratory problems or stomach problems or cancers, it's really just not. It's really not a good diagnosis to have. But it can lead to blindness. It can lead to actual cardiovascular disease. And most importantly, if this gets out of control or our patients that are diabetics are not following their diets or taking the medications like they're supposed to, this can actually shut down their kidneys and they can go into kidney failure. So during this lecture, we're going to really spend some time on diabetes, but as you guys, as EMT basics, we really need to make sure that we understand the different types of symptoms between a hyperglycemic or somebody that has too much sugar in their system compared to a hypoglycemic, somebody that has a low level of sugar in their system. And really, when it comes to diabetes, the big problem is the fact of the insulin. It's either there's a lack of insulin or the insulin that they actually produce is ineffective and not designed or not able to do the actual function that the insulin is supposed to be doing for our body. Okay, so when we're talking about diabetes mellitus type 1, which is just diabetes, really, just kind of the actual medical term that we use for diabetes, this is an autoimmune disorder, and it's actually the immune system produces antibodies against the pancreatic beta cells. So the immune system actually attacks the pancreatic beta cells, and remember that the beta cells is where the actual insulin is produced. So if our body is killing off our beta cells, we're not able to produce that insulin. So for diabetic type 1, there's a lack of insulin due to this. Okay, so the problem with diabetes type 1 diabetics is that they have a lack of insulin to begin with because it's an immunal response. The body's attacking the beta cells found in the pancreas, and the beta cells are not able to produce insulin in the first place. Okay. So without insulin, that glucose is not able to enter the cell, and the cell is not able to produce efficient energy without the glucose. So the type 1 diabetics is usually people that happen to either be born with it or develop it early in their childhood stages. When the actual immune system destroys the ability to actually produce the insulin, these people need to obtain insulin from outside source, and most of the time these are the people that are actually giving them shots of insulin in order to help regulate their blood sugars and their sugar levels in their blood. The type 1 diabetics cannot survive without insulin. Okay, they need this insulin from the external source. If they don't get that insulin from this external source, they're going to die because they're not going to be able to get the sugars into their cells and process the sugar for energy. Okay, and then these people usually have to check their blood sugars numerous times during the day, usually before and after they eat, when they wake up, before they go to bed. So we're looking at anywhere probably between 6 or 7 times a day at a minimum, really, for most of the people that are type 1 diabetics. Most of these people actually have what's called an insulin pump, and the insulin pump is actually usually the actual insertion point is somewhere in their abdominal cavity. And what it does is it actually measures the glucose levels for them, and it will automatically give them the amount of insulin that they need. It's kind of a newer technology. I would say probably within the last decade, I think. Could be very wrong about that, but it seems like to me it was within the last decade, so I'm going to throw that out there. But really, this is very efficient for people that actually have type 1 diabetes because the machine actually monitors everything for them. Now, that being said, the machine can malfunction, right? It is a machine. And there are obviously diabetic emergencies that have developed because their machine is malfunctioning, whether that machine is not reading the glucose levels correctly. Let's say that machine reads that those glucose levels too high and the patient gets too much insulin. That could be very bad for our patients. Or it's not reading the amount of glucose in the blood correctly in the first place, and they're not actually getting enough insulin in order to actually process the glucose as well. So at times it could be a double-edged sword for our patients, but it is rare to have an insulin pump malfunction. You guys will definitely get more training in that when you guys get into intermediate, and then more when you guys get into paramedic. So type 1 diabetes, it is the actual most common metabolic disease of childhood. And new onset patients will have symptoms related to both eating and drinking. And we're going to talk about the 3 P's of diabetes, which is polyuria, polydipsia, and polyphagia. Okay? Polyuria is they cannot stop peeing. They have to pee all the time. We'll talk about that here in a little bit. Polydipsia is they can't quench their thirst. They are always thirsty. They feel like they need to keep drinking and stuff like that in order to try to quench their thirst. And then polyphagia is they are hungry for food all the time. They feel like they can't eat enough food in order to satisfy their hunger. They could also have weight loss. and they can also have fatigue. So we have a very wide variety of symptoms here, right, for diabetes, and we're going to try to really kind of pinpoint the signs and symptoms for hyperglycemia and the signs and symptoms of hypoglycemia for you guys. So the problem is that when the patient's blood sugar actually gets too high, the kidneys actually become overwhelmed, and they actually start peeing out the sugar from the body. And actually, this is one way that doctors, your primary care physicians, actually test for diabetes. If you guys have ever given a urine sample to your doctor, I guarantee they have checked this to make sure that you're not spilling sugar into your urine. So again, polyuria, you guys will need to know these definitions for basic. Polyuria is that frequent urination. Polydipsia is that increased fluid consumption. They just feel like they cannot get enough water into them. Hopefully they're drinking water. Or polyphagia is that severe hunger or increased food intake because they just can't seem to satisfy their hunger. When the actual blood patient's glucose is unavailable to the cells, the body will actually turn to burning fat for its energy. And when the body actually does this, the body actually produces an acidic waste known as ketones. Okay? As the ketones level in the body actually go up, they'll spill out in the urine. So again, we are overworking our kidneys at this point. The kidneys really kind of start having a hard time kind of balancing that acid-base balance. All right, the patient's going to start breathing faster to try to compensate for the actual malfunction of the kidneys at this point, and deeper. This is huge, guys. Those are two big signs and symptoms. Diabetes type 1, when that sugar is unavailable, when they have that, when that glucose is unavailable into the cells, okay, that the insulin is not working. So the glucose can actually be rising and getting higher and higher and higher because the glucose isn't about to go into the cells. It's just kind of hanging out in the blood system. They're going to start breathing faster and they're going to start breathing deeper, okay? The other thing with when we're talking about producing ketones, all right, they're also known as what's called Kussmaul respirations. It's a deep, fast respirations. Please make sure you guys know what Kussmaul's respirations is. This is the body's attempt to reduce the acid level by releasing more carbon dioxide through the lungs, okay? That's what the actual definition of Kussmaul's respirations are. Okay, so when the fat starts to metabolize and ketone production, which is the byproduct of the actual fat being metabolized, we can have the sugar is still continuing to rise because we're still eating, but we just don't have the insulin to actually get the sugar into the cells. So we can get into a disease process known as diabetic ketoacidosis, okay, DKA for short. This is where we have too high a blood sugar in the body, and our kidneys are having a really hard time right now. This can, usually the classic signs and symptoms is a sudden onset of abdominal pain, body aches, nausea, vomiting, altered mentation, and unconscious. Basically, it's almost like flu-like symptoms without the fever. These people need to go to the hospital. These people need a ton of fluid, and they also need to get some insulin in them in order to process the sugar. Guys, this is very hard to recognize in our patients, and unfortunately, if we can't recognize this, our patients are going to die. They're dying very quickly at this point. When the patient with DKA has altered mental status, we really want to make sure that we're trying to utilize bystanders on scene to see if they actually know the patient or possibly friends and family, so we can get a history of what might be going on with the patient. These people more than likely are going to be altered in some way, shape, or form. And we'll talk about more signs and symptoms of hyperglycemia high blood sugar later on in this lecture. But we definitely need to start moving up the actual BGL check in these patients. Really, anybody. We talked about AEIOU tips in neurology, your new mnemonic for why somebody might have altered mentation. This is something that, and any of those, really, any of those, anytime that your patient has any kind of altermentation, we need to move up the actual BGL testing a little bit further in our assessment than maybe we might have possibly done it. We don't want that to definitely be one of the last vital signs we take. We want to really kind of move it to the front line to make sure that we're not dealing with a diabetic issue, because it's just going to keep getting worse. That's all there is to it. And when we're dealing with a diabetic, it can get worse as we're looking at them. That's how fast this disease process can actually take place, depending on the actual patient, their comorbidities, and how bad of diabetic they actually are. But really, when we're talking about BGLs, this is usually any BGL that is 400 or higher. Now, your normal BGL for anybody is anywhere between 60 and 120 milligrams per deciliter. Okay, so we're talking about 400 milligrams per deciliter. This is making their blood extremely thick because of the sugar that's in there. And it's really going to start taking a toll on the heart. It's really going to start taking a toll on the kidneys, possibly leading them to some kind of kidney failure. And of course, our lungs are going to compensate to try to blow off that excess acid, which in turn is going to make our patients more dehydrated, which could actually increase the fat metabolism and keep making their sugars go up and up and up. This is just a disease process that is pretty nasty on our patients, and we really have to be able to make sure that we are recognizing the signs and symptoms of this. Okay, moving into diabetes type 2. This is caused by a resistance to the effects of insulin at the cellular level. So these people do not have a problem making insulin. The problem with the insulin that these people make is, for whatever reason, it becomes ineffective with how much sugar is actually in their body. This is definitely developed later in life, or it's more common to develop later in life. It happens to be associated with obesity and poor diets, which actually increases the resistance to the effects of insulin. The pancreas will actually overproduce more insulin to make up for the actual increase in levels of the blood glucose. And unfortunately, dysfunction of the cellular insulin receptors will actually occur. So again, it's not the actual process of producing insulin. It's just the insulin, and due to the fact that they're having poor diets and whatnot, when that insulin tries to go and open the gates, it's not necessarily able to do that. Insulin resistance can sometimes be improvised. We can actually change this on some patients if we can get their diets under control and the patient starts to exercise in order to lose the extra weight. Our type 2 diabetic friends, they're not necessarily taking insulin shots. They're more than likely taking some kind of oral medication to help treat the actual type 2 diabetes. There's still some increased secretion of insulin, which can pose a problem that if for whatever reason their body sometime during the day decides to produce more insulin, which happens to be around the same time that they take the medication for it, they can severely drop their blood sugars, okay? And then we got a whole other set of problems, right? So we already kind of talked about high blood sugars, and we're going to really kind of start talking about low blood sugars now. I don't want you guys to think that only type 1s get high blood sugar and only type 2 gets low blood sugar, okay? It can go either way for each one of these disease processes, all right? So when we're talking about diabetic type 2s, there are some effects of the actual glucagon and the decrease of release of glucose stored in the actual liver, okay? This is problematic as well, right? Because as soon as that, let's say their pancreas just decides to spill out some insulin, The cells decide to accept that insulin, but they already took their type 2 diabetic medications. They have released the kind of glucose storage in their liver, which can now send their sugars into a high overdrive. It can actually spill too much sugar out of the liver, and then we have to actually get these people to the hospital in order to help them restore their glucagon levels in their liver so that they can have that storage as a just in case. Again, really nasty process, guys. There are some type 2 diabetics that do not take oral medications, and they are prescribed injectables for their type 2s. These are usually people that are extremely obese, and I guess I shouldn't profile like that, but usually they're extremely obese. Their diets are not well at all, or they have some other kind of metabolic disorder on top of the diabetes that's keeping them actually obese, even though their diets might be good. So again, a lot of different combos with diabetes. I would suggest that you guys read up in your books on diabetes type 1 and type 2 for the exam, or before you guys take the exam on this topic. So again, this is usually diagnosed by primary care physicians, whether they have done an A1C test, which is a blood test, a blood draw test for their patients, or they possibly just decided to get a urine sample and they found out that the patient is spilling glucose into their liver or into their urine, or possibly even they can find proteins in the urine as well, which is not good either. But when we're talking about high glucose levels, it could be a recurrent infections, okay, that the patient might actually be experiencing. These are patients that might they can get just the common cold. You know what? Even less than that, they can get sinus infection. And for whatever reason, this sinus infection lasts months, right? And they finally go to the doctor, and this is how usually type 2 diabetes is confirmed in our patients. Visual changes, right? They might have been able to see really good before, but for whatever reason now they might be losing their peripheral vision, or they might be developing tunnel vision or blurry vision, or they might be seeing spots or something like that. And poor circulation, poor perfusion at the cellular level, which usually kind of starts down at the feet. We're going to talk about something called neuropathy later on, which is actually numbness in the feet, where people actually get diagnosed. And the funny part is this, I shouldn't say it's a funny part, it's just a funny coincidence is usually these are the people that they're just sick of being fat, right? So they try to exercise and they start to try to do cardio and they start to try to run or whatnot. And when they're running, they actually develop this numbness in their feet. Guys, that's not normal, right? So they might try to go and change their shoes or something like that. Maybe that's the problem. They go through all these different things and nothing changes. And that's actually the start of neuropathy. And that's how they actually kind of get diagnosed with type 2 diabetes. So unfortunately, sometimes this comes out being good. And that way the doctors can kind of regulate the blood sugars and get these people to hopefully start living a healthy choice lifestyle.